morning, Chair. Chair, today the inquiry will be hearing evidence from two experts, Dr. Davidson and Ms. Nelligan. Further details of their roles and experience will be given by them when they come to the witness table in just a few moments. Between them, Dr. Davidson and Ms. Nelligan will give evidence relating to the provision of mental health services in the UK. They will consider and will give evidence about what constitutes good care, and they will address the key principles and standards relating to the delivery of that care to mental health patients. At this stage of the inquiry, Dr. Davidson and Ms. Nelligan will not be looking at any specific details or any individual case, but they will be providing an overview of how care is provided. This will be important, explanatory and contextual evidence. There may be aspects of today's evidence that are difficult to listen to, however, and for some people it may not be possible to sit through the two sessions. And as with the other days, anyone in the inquiry room should feel free to leave at any time. May I take this opportunity, however, as previously outlined, to remind those engaging with the inquiry that emotional support is available for all those who require it, and the well-being of those participating in the inquiry is extremely important to the inquiry. Again, as outlined, we have present here today, again, emotional support staff from Hestia, an experienced provider of an emotional support at these types of hearings. And they are currently in the room, I believe, and they've raised their hands. I'm very grateful. They can be identified by their orange-coloured scarves. There is a private room downstairs where anyone who needs emotional support can talk to the Hestia support staff. If you prefer, you can speak to a member of the inquiry team. As has already been indicated, we are wearing purple-coloured lanyards, and we can put you in touch with the emotional support staff. For those following the hearing online, information about the emotional support that is available can be found on the Lampard Inquiry website at lampardinquiry.org.uk, and the support tab is near the top right-hand corner. We want everyone engaging with this inquiry, in whatever way they're engaging, to feel safe and supported. Chair, I will now hand over to another member of the Council to the Inquiry team, Tom Coke-Smythe. He will ask questions of Dr. Davidson and Ms. Nelligan, who I can see are waiting in the front row, ready to come forward. Thank you, Chair.
Thank you. Thank you. I should make clear, firstly, as was said in opening, that this is introductory evidence, and both experts will be covering a significant amount of ground at a high level. Dr. Davidson will first be dealing with some of the historical context and background to mental health inpatient care before dealing with admissions, and I then intend to focus on care whilst an inpatient with Ms. Nelligan from a nursing perspective, before finishing with post-discharge planning and examination of some key principles in respect of reviews and investigations. And Chair, I should say that given that their evidence is very much complementary to one another, we'll be hearing from both experts together. And the benefit is that will allow each to comment on one another's evidence from their respective professional standpoints as we go along. So, Chair, can I now call, please, Dr. Davidson and Ms. Nelligan?
I, Ian Alexander Davidson, do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
I, Josephine Maria Nelligan, swear by Almighty God that the evidence that I shall give shall be the truth, the whole truth and nothing but the truth.
Thank you. Dr. Davidson, can I start, please, by asking you to confirm your full name?
Ian Alexander Davidson.
And it's right that you are giving evidence in your capacity as a consultant psychiatrist.
Yes.
And it's right that you have provided a report which is dated the 18th of March 2025.
Yes.
And I think you've got that in front of you.
Yes.
But for anyone who's following, that report is signed at page 57. And although dated the 18th of March, it's also right it was updated with some corrections and further references on the 2nd of May of this year.
Yes.
Just looking at the report, you have signed it and you have a statement of truth. You've also completed an expert declaration, and as part of that you make clear that you understand your duty as an expert.
Yes.
And that nothing in that report has been included or excluded without you forming your own independent view.
Yes.
And I think you've got that in front of you, and please do refer to that report at any point during my questions, and I will be referring to various paragraphs within it.
Thank you.
Can I confirm at this stage that, to the best of your knowledge and belief, that report is accurate?
Yes.
And do you wish for the contents of that report to stand as your evidence to the inquiry?
Yes.
As a result, I'm not going to be asked about every aspect of that, but I'll be going into certain details and asking certain questions on aspects of it. Ms Nelligan, can I turn to you, please? Can you tell the inquiry your full name, please?
Josephine Maria Nelligan.
And it's right that you're giving evidence in your capacity as a registered nurse.
That's right.
And you provided a report dated the 27th of March of this year.
Correct.
And we've got that in our bundle at page 995. And at page 35, internally of that report, you signed the report. Is that right?
Yes.
And you've completed the same declaration and statement of truth as Dr. Davidson.
Yes, I did.
And again, do you have that in front of you?
I do.
And again, please do refer to that at any point during my questions. And can you just confirm that the contents of that report remain accurate to the best of your knowledge and belief?
Yes.
And again, do you wish for the contents of that report to stand as your evidence to the inquiry?
I do.
And again, as with Dr. Davidson, I'm not going to go through every aspect of that report. That will obviously stand as your evidence in addition to my questions. Can I start now then, please, by Dr. Davidson just dealing with your experience, and you set that out in your report, for those who've got that in front of them, at page 3.
Yes.
And perhaps I can just summarise in the following way. You're registered with the GMC as a doctor.
Yes.
You're on the specialist register in general psychiatry.
Until the 31st of March, when I retired.
Thank you. And your most recent role prior to retirement in March of this year was as a consultant general psychiatrist at the Cheshire and Wirral Partnership NHS Foundation Trust.
Yes.
You first qualified in 1980, and you've been a practitioner therefore for over 44 years.
Yes.
And your experience includes both inpatient and community psychiatry.
Yes.
And you maintained direct clinical practice up until 2022.
Yes.
And in the course of your career, is it right you've contributed to the work of the Royal College of Psychiatrists?
Yes.
That included acting as the college's clinical lead during Lord Darcy's investigation into the NHS.
Yes.
You were also appointed as the Royal College inaugural autism champion between 2017 and 2021.
Yes.
And you have held a number of clinical leadership and management positions in respect to mental health.
Yes.
And those have included medical director,
Yes.
deputy chief executive and interim chief executive at the Cheshire Wirral Partnership NHS Foundation Trust.
Yes.
And nationally, you've had experience working for the Healthcare Commission, the Public Sector Ombudsman, and also as a professional advisor to the CQC.
Yes.
And it's also right to say that you have over 25 years experience acting as an expert in legal proceedings.
Yes.
And you also sit as a medical member of the First Tier Tribunal in Mental Health.
Yes.
Ms Nelligan, then turning next to you and your experience, set out at page 3 of your report. You are a registered nurse in the field of learning disability. You also hold a diploma in community nursing and an MSc in practitioner research. Is that right?
Correct.
And you retired from practice in July 2024, is that right?
Yes.
And you first qualified as a nurse in 1985.
Yes.
And you worked in inpatient and community mental health settings up to 2004.
Yes.
And from 2004, is it right that you moved into various nursing leadership roles with a focus on practice improvement and professional development in mental health?
Yes.
And you've been a Deputy Director of Nursing, which has involved focusing on nursing practice and standards, and leading in respect to the organisational clinical policies associated with that.
Yes.
And you've also been responsible for monitoring processes linked with external standards, such as those from the CQC.
Yes.
And you've held roles as Chief Nurse and Quality Officer, and you've had experience delivering improvement at 3 trusts, which have had significant care quality challenges. Is that right?
Yes.
And you've also contributed to setting national standards of inpatient care, most recently with the Culture of Care Standards for Mental Health Inpatient Services 2024. Is that right?
Yes. Yes.
And finally, it's right, you also work as an external executive reviewer for the CQC.
Yes.
Turning then back to Dr. Davidson, if I can, please, and just dealing with your report and your instructions firstly. It's right that you've been instructed to provide a report to establish appropriate benchmarks for what should be expected by way of minimum standards during our relevant period.
Yes.
And it's right that during your report, what we could see is that you've generally focused on general principles rather than minimum standards. Is that a fair summary?
That's correct.
Can I just ask you this? Given the period under review and the breadth of the topics, how practical is it for you to provide minimum and indeed gold standards throughout?
Extremely difficult because there's a lot of variety.
And it's also right that your report is intended as an introduction, so you don't go into detail in various different areas, but it's designed for context. Is that right?
That's correct.
And you set out there broad themes and consensus, and you also set out common factors influencing care. Is that right?
That's correct.
And is it also the case, unless you've stated otherwise in your report, your opinions are based on your professional experience?
That's correct.
And that comes from your many years as a practitioner?
Yes.
It's also right to say your report is national. It doesn't purport to address Essex. Is that right?
That's correct.
And it doesn't comment on any particular case or individual.
That's correct.
And Ms Nelligan, do all those points also apply to your report?
Yes, they do.
So, Dr. Davidson, can I start then, please, by dealing with your section 1? And this is where you set out, by way of introduction, some of the key changes between 2000 and 2023. And I'm just going to start by looking at your first paragraph, 1.1. you deal there, the first significant event that you identify at the start of 2000 is the National Service Framework.
That's correct.
And you describe that as a significant event, and you set out how the aim of that was to stop what was described there as a downward spiral of mental health services. Can you just, in outline, tell the inquiry what was significant about the NSF, please?
The key things about the NSF were, one, it was an attempt to set out principles and what good could look like. Another important point about the NSF was it brought significant new resources into mental health. Another important part about the NSF was it tried to pull together the existing evidence that existed at the time to support clinical decision making at a very high level.
And you set out at 1.2 of your report the fact that there were pressures which included demand exceeding capacity, and you say that that would often lead to offloading of cases rather than continuity of care, and pressure to see new referrals leading to too little time for ongoing essential care and treatment. Can I just be clear, are you referring there to that period prior to the NSF, prior to 2000?
In this section I am.
And you also deal there with the model of the one local team that you refer to.
Yes.
Can you just start by telling us what you mean when you use the term one local team?
So, first of all, a team is not like a football team. It isn't defined as you'll have 11 players on the pitch at any given time. A team is more like a band or an orchestra. It varies enormously from one place to another as to who's in the team. But the purpose or the principle behind the one local team was that a particular team had responsibility for a particular catchment area. That meant they couldn't refuse to see people from that catchment area. Everyone from that catchment area was their responsibility. Initially, back in the time we're talking about here, it was very, very common. It was in fact normal practice that the same consultant psychiatrist who worked on the community team would also be allocated a certain number of inpatient beds to which those team patients would normally be admitted and would therefore be the consultant psychiatrist for them whilst they were an inpatient as well.
And in terms of one local team, we've heard, we've seen reference in your report to the CMHT,
Yes.
Community Mental Health Team. Where does that fit when you refer to one local team?
At that time, they were almost entirely called community mental health teams. Over the course of the next 25 years, various names have come into play for teams doing similar but not quite the same. So CMHT is the generic team, is the generic name still.
And again, just looking at the beginning of the period and the one local team model, where was the mental health inpatient care being provided by?
So the mental health inpatient care would be in whichever local inpatient unit was for that area. That particular team would have an allocation of beds, typically on one ward, but sometimes on different wards. And the expectation was that wherever possible, a person who was admitted from that catchment area went to that team bed and had the same team psychiatrist providing continuity of care. That didn't always happen. Sometimes people would end up in different beds because of bed pressures, but the vast majority of times that was the model.
So just perhaps summarising there, at the beginning of the relevant period, one local model, we're looking at a community mental health team, and as I understand your evidence, there is also acute inpatient beds linked with that community mental health team. Is that right?
Yes, and just to specify here, I'm talking about adults and older adults. For children, things were slightly different even back in those days, but the same principles applied.
Thank you. So that's the model at the start of the period, and you describe the NSF abolishing the one local team model and replacing that with multiple teams. Is that right?
It wouldn't be true to say that national policy abolishes things. It would be true to say that national policy recommended doing other things. So over time, different places would do different things at different times. It's not that a national edict comes out and from tomorrow you must do this. The recommendation is that you should be going down different routes. So it gave very strong recommendations that certain specific new teams should be developed. Other new teams had been developing, as I say in my report, such as the older adults. But the NSF made a very distinct set of recommendations about new teams, yes.
And is it right that the community mental health team split generally into adults of working age and separate older adult teams?
That became increasingly common, yes.
And you refer in your report to 3 new teams, and you describe those as the early intervention in psychosis team,
Yes,
the crisis resolution home treatment team,
yes,
and the assertive outreach team.
yes.
And you describe in your report that one downside was more fragmented and discontinuous models of care and treatment. Is that right?
Yes.
And can I just pause there and ask you to explain in a little bit more detail what you mean by that, please?
So every time there's a handover, some information gets lost, some information doesn't get transmitted correctly. That's the way human beings operate. There was also potential barriers, so that you might have a referral form and then someone might be deemed inappropriate for this team, so they would not get access. So there were various types of barrier which come in when you set up multiple teams. They're inevitable when you set up multiple teams, but unlike the old team where one team was responsible for everything in that catchment area and they couldn't say it's not us, you now had a situation where different teams could say not us.
So essentially more people involved, more opportunities for things to be potentially missed.
Or misunderstood.
It might just be helpful at this stage just to look at some of the teams that you refer to.
Mm-hmm.
And I believe you set those out in your Appendix 2.
Yes.
That's your page 61.
Yes.
And perhaps we could have that up on screen, please. So it's Dr. Davidson's report, Appendix 2, page 61, please. So this is an overview of the mental health treatment team types. And we can see, firstly, in 2000, we had the community mental health team as the main community team. We referred to that. We also had CAMS and learning disability services. You then describe the teams splitting. The 3 new teams, we can see it, paragraphs 4, 5, and 6. And just dealing with those briefly, the early intervention in psychosis team, you say there was it was the point of access for a first episode psychosis. Can you just explain a little more about what the purpose of the early intervention psychosis team was and how it operated?
So the purpose was, it's lots of research evidence shows that the longer someone is in an untreated state of psychosis, the more harms they will suffer, the more disabilities that will occur, and the harder it is to treat. So the purpose was to get people into a specialist team as quickly as possible so they could access to what was recommended as the best treatment for early psychosis as soon as possible. It was based on international models, and the idea was there should be no delay, and therefore, rather than having to go through multiple teams to get to that point, you could be directly, as soon as someone suspected you of psychosis, you could be referred directly to the early intervention psychosis team, and hopefully within 2 weeks be on treatment.
And the next team you refer to there is the crisis resolution home treatment team. How does that fit in respect to the early intervention psychosis team?
It doesn't directly. crisis resolution and treatment team was really to address the fact that some people were presenting in crisis, particularly out of hours, when there had been historically no service. However, if someone presented to the crisis resolution and treatment team and was identified as having a first episode of psychosis, they should refer them directly onto the early intervention psychosis team. But they might be seeing a lot of other people who didn't have psychosis.
And finally there we've got the assertive outreach teams. He described that as a tertiary service for those who had deteriorated to the point that they needed much more intense input for longer than could be provided by the crisis resolution home treatment team. In terms of other teams, just an overview so we can see and are familiar, those include the perinatal services, personality disorder and complex emotional needs teams, substance misuse and alcohol misuse services, community rehabilitation teams. Separately, we also have CAMS, is that right?
Yes.
CAMS, am I right, was in existence at the start of the relevant period?
Yes.
So not a new team.
CAMS developed new teams within CAMS services, and at the beginning of the period, CAMS services were often not 16. By the end, they were more often going up to 18. So there were changes within CAMS services, but relatively fewer new teams developed.
And we also see learning disability and community teams and other teams such as gambling services, for example.
There have been a wide variety of teams developed, yes.
So in summary, a number of further teams, many of them new.
And tending to be focused on specific issues, yes.
So going back to section 1 of your report, and I'm looking now at your paragraph 1.9, you say that the downside was that core community and adult inpatient services had to absorb increasing demand, which wasn't eligible for the new services, so time per case fell. Can you just explain what you mean by that, please?
So as the earlier paragraph set out, when these new teams were recommended nationally, there were often annual targets about filling them, and these were not usually fully funded. So funding, if you prioritise funding them, you have to deprioritise funding something else. So the result was that if you got into the specialist teams, they were much lower caseloads, much more time per case. They were much more attractive places to work by and large, and they were also much better if you were a patient receiving a service because you were getting much more intensive services. The result of that was that staff left the core community and acute services to go into these more attractive teams, but also there was less funding per case available for those teams, even as demand continued to rise. So the funding per case gradually dropped for those other teams.
So in summary, you've got more teams, and for the core teams, so the community mental health team, for example, in real terms, less money per case. Is that right?
Yes.
You deal in your report, moving on to 1.17, you say by 2017 it was clear that pressures were becoming very severe in the system and flowing into increased use of out-of-area beds. Just pausing there, I want to ask you about out-of-area beds. Firstly, in very basic terms, what does that mean, out-of-area beds?
Out-of-area beds is a very loosely used term. NHSE, as I put in my report, did try to produce some guidance to help people identify what was called an inappropriate out-of-area bed. In a general sense, an out-of-area bed was a bed that was not local to and directly connected with your community services. That could be within the same trust, it could be in a different organisation, it could be geographically the other end of the country. So it's a very broad term. And NHSE then tried to bring in this definition of inappropriate out-of-area beds to define a group that they were particularly concerned about. But that left, as I say, the situation which was there were a group who were not in their local trust bed, were in some other bed, but were not very visible.
So just focusing on where you use the term out-of-area beds,
Yeah.
which definition are you using there?
So I'm obviously, in terms of the formal thing, the inappropriate out-of-area beds, it's the national NHSE one. In terms of out-of-area beds, the broader term is for me that you're not in a local unit which is linked to your local team.
And the inappropriate use of out-of-area beds, that term from NHS England, can you just help us? What exactly does that mean? What makes it inappropriate?
So sometimes it will be totally appropriate. For some things, there are regional or national. Because they need such special services, you will need to go to a regional or national centre, and that's totally appropriate. Sometimes a person will end up, for example, someone from the north of England could end up in London and have to be admitted to a London bed whilst you make arrangements to transfer them back up to the north of England, because you can't transfer them a day. That again would be considered appropriate for that period to emergency admission to get them back. However, where you're sending someone from your local area to a bed potentially hundreds of miles away, that would be considered inappropriate. The NHSE definition then tried to make some caveats on that, so that if it was to a commissioned bed, a locally commissioned bed with the same access to your local services as you would have from, say, a trust bed. So, for example, the argument was, if this was a trust unit and across the road there was a non-trust unit, in practical terms, it may not be out of area for the person, even though it's technically not in the trust. So it is complex to try and cover this in a very general report like this, but essentially, the further away you are from your local team and the less information sharing there is with your local team and the less direct contact you have with your local team and your family and friends and relatives whilst you're in that unit, the more likely it was to get deemed as being out of area.
And who makes that judgment ultimately?
Ultimately, that was a local decision by local providers and commissioners.
Sorry, perhaps slightly different aspect of that question. Who makes the judgment as to whether it's inappropriate?
The same, local providers or commissioners.
And you say in your report that use of out-of-area beds are generally less effective and less safe with greater discontinuity of care than if admitted to a local bed.
Yes.
Just briefly, why is it that they're generally less effective and safe?
Particularly in the early stages, particularly when people were using paper records. If you went somewhere that was 100 miles away, your records may not be there, so someone would turn up completely unknown. They may have little knowledge of your local area or what the local nuances of culture or what services were available locally. It would be much more difficult for you to be visited by family and friends. If you did get leave, it was much more difficult to test how you were doing on leave back in your local area because you had to get there. And information sharing was often not good. So there were potentially situations where someone was discharged from such a unit without the local team even knowing they'd been discharged, or the local team having asked for something from an inpatient admission but not the receiving team not knowing that. So again, in a very general report, there are lots of reasons. I'm just setting up that there were more complications.
Sorry to labour this point,
Yes.
but I think what you're identifying is that you've set out a number of principles which might identify something as inappropriate.
Yes.
Less access to information,
Yes.
further away from family, further away from... but you could still have a local commissioner suggesting that that was appropriate.
Yes.
Thank you, Chair. Just moving on slightly and still dealing with out-of-area beds, it's also right that within that equation there are private providers.
Yes.
And is it right a private provider could be within area or it could be outside area?
Yes.
And generally speaking, what, if any, downside might there be to a private provider?
Again, particularly at the early stages, private providers typically did not have access to the records that the trust would hold, and equally the trust would not have access to records that the private provider held. Over time, for what became called appropriate out-of-area beds, information sharing protocols improved, but it was still generally more clunky and it was not so good. Private providers have got a different financial basis to public providers, and so they have a duty to return profits to their shareholders, which means that they generally will be charging higher prices. The continuity of care, for example, if your care coordinator wished to come and see you, particularly in the early stages, was more difficult. They couldn't just pop in like they could do into your local unit. They would have to make appointments, and sometimes you'd go to a unit and you'd be asked to see the person not on the ward but in an interview room off the ward. So I'm not saying these things applied everywhere. I'm saying in general these were the sorts of things that did happen.
Just perhaps being a bit more specific on that, in terms of out-of-area beds, so moving on from providers, but out-of-area beds in particular, to your knowledge, is there any correlation between out-of-area inpatient treatment and negative impacts? So, for example, increased recovery times, increased incidence of self-harm, suicide, etc.?
The general consensus is that the evidence suggests that those things do increase.
You also deal in paragraph 1.18 with the pressure, and you deal with this also above, but the pressure to provide beds which wouldn't be deemed inappropriate. And you describe this leading to a culture of an admission as a last resort rather than admission when optimum to do so.
Yes.
Can I just focus on that point there, when optimum to do so? When is it optimum to admit someone as a mental health inpatient, generally speaking?
That's obviously very individual and situation specific, but in general it's at the point where you've reached the point where community care is no longer viably likely to provide the necessary improvement. It's very difficult to personally define that on an individual case without looking at an individual case.
Of course. And how did that admission of last resort issue come about?
The admission of last resort, if you have run out of local beds and the only beds are available far away, the pressure not to admit an inappropriate out-of-area bed was huge, and therefore there was huge pressure to try and muddle on with someone in the community or to keep someone sitting in what's often called A&E, in NHS terms is often called urgent emergency care, but it's the A&E department. So you were keeping someone in an inappropriate place waiting for a local bed to come up rather than getting them into a bed. It also led to increasing focus upon risk in a way which was defined in a way which was immediate likelihood of harm. So there's always risks in life, everything in life has risks, but it became how likely was harm to occur in the next day or two, rather than if we bring you in now, are we likely to prevent serious harm in the near future? And there was also the financial thing, that these out-of-area beds were usually not in a block commission, so they had to be paid for separately, which then came out of the budget for providing other services.
Just moving on in the chronology in terms of the background and context, it's right that in 2019 the long-term plan came into effect, including the mental health implementation plan, and you described that bringing significant new investment and an emphasis on supporting and strengthening core community and acute services. Did that include CAMS?
The long-term plan does include CAMS, yes.
You then set out 2019, the Community Mental Health Framework was published, setting out the principles and values to be expected in delivering good mental health services. And the next significant event you describe is COVID, and you describe a rise in mental health demand, which was exacerbated by COVID. Is that right?
That's correct.
So, in summary, pressure's increasing towards the end of the relevant period. Is that right?
That's correct.
And in summary, looking at your paragraph 1.24, you describe investment throughout the period, but not always in keeping with rising need and demand.
That's correct.
You say there were a wide range of new teams, services and therapeutic approaches, and you say that more people than ever were being treated.
That's correct.
You then make this point. There was a lack of routine reporting data, other than in respect of what's now called NHS talking therapies. Is that right?
Outcome data, yes.
And the result of that is that we can't accurately measure how effective that care in that period was. Is that right?
That's correct.
And am I right? Is that a major limitation to assessing the relevant period and those changes?
It is. And compared to other areas of healthcare, it's very unusual.
And are you able to say, we know routine data wasn't reported, are you able to explain why that was, or not?
I can give an opinion on it. I can't verify that opinion is the full opinion. Essentially, for about 40, 50 years, there was a lot of debate in mental health about what constituted an outcome. And in one sense, this went from helping the person to have a perfect life with all their needs met at one level to specific changes at another level. And there was never a national consensus on how to measure what we were trying to achieve. Compared to other things, for example, when I did the work in Girth came out of orthopaedic surgery. In terms of hip replacements, it was very, very clear. There were reporting measures that you did for that. There were no equivalent reporting measures for mental health. So the problem was lack of consensus about what would be acceptable as an outcome measure. That has recently changed, as I've said in my report, and there are now agreed outcome measures that should be done. Early intervention psychosis did do outcome measures, but they tended, the reporting of them was unfortunately at national level on whether or not there were two separate outcome data points recorded, not what was the change between them. So we knew that outcomes were being measured, but there was no national reporting as to what change happened between those points.
And does it follow from what you've said that you would support going forward national recording of outcome data in mental health?
I don't see how we can drive significant improvement without that.
And can you just tell us, as we stand now, how far is there left to go, in your opinion, to achieving that?
We are at a point where, in terms of community mental health, adults and older adults, and CAMS as well in different ways, there should now be routine reporting. What isn't yet, we have not yet reached the stage where that routine reporting has been going for long enough and consistently enough for national reports to have been produced, to my knowledge. They were hoping to produce the first reports in 25-26, which is the year we're in. They will be provisional reports, because when you recommend that something's done, it doesn't mean it gets instantly done. So the data quality may be poor, it may be patchy, but we should start to get outcome data routinely reported by this year at some point, was the expectation. Obviously, there have been a lot of changes at NHSE since that, so I can't comment on whether that's still true, but that was the last expectation that I was aware of.
Thank you. I want to move on Now to another aspect of your introduction, and you say that few people, even with severe mental illness, need or benefit from inpatient care and treatment. Is that right?
That's correct.
Just following on from that, what types of, in a general way, what type of patient or condition does benefit from mental health inpatient care?
So you can't say condition, because all conditions can be treated at home if you get them early enough, and you can do intensive support if needed to. So even back in the 1980s, 90s, some people with psychosis were being treated at home, never needed admission. So it would not be condition specific. It would, however, be in terms of what's practically viable. And that's the critical thing. So, for example, it's much more difficult to do intensive home treatment if someone has no fixed abode, as a practical example. It's more difficult to do effective treatment if the person is declining to accept the necessary effective treatment, and therefore, if they need to be detained under the Mental Health Act, that will be to a bed to enable that to be done. It can also be that, for example, certain medications like clozapine, particularly in the early stages, people were very reluctant to do clozapine titration in the community. So people, even if they were willing to have it, were told you have to go into hospital so we can start it in hospital and then you can come out again. So it's based upon pragmatics and practicalities of what's reasonably available at that time in that area to try and best meet that person's needs. And if it's not viable to do it in the community, but it is viable to do it in hospital, then you would bring them into hospital. Clearly, if it's not viable to do in hospital either, then there's no point in bringing them into hospital.
So not condition specific, but just to summarise, a major factor might perhaps be the severity.
Severity comes into it, and it's a question of how you can help the person and their family and anyone else involved manage that severity. Severity is not the overriding issue, but it's one of the factors you would take into account.
And from what you said, the other key factor is personal circumstances of that individual.
It's very much person-centred care, yes.
At 1.27 of your report, you highlight the growth over the 21st century of numbers in contact with mental health services. And you say that nationally, rates of serious untowards incidents, including deaths, did not significantly rise during the relevant period. And you make reference in your report to data taken from the National Confidential Inquiry into Suicide and Safety in Mental Health, referred to as NCISH, is that right?
That's correct.
Can I just ask you some questions about that, please?
Yes.
My first question is, what is NCISH?
So NCISH is a non-governmental body which was commissioned by, I think, DHSC, Department of Health and Social Care originally, to set up a national review of deaths by suicide and homicide linked to mental disorder. It's been running for a long time. It has sequences, as I refer to in my report. The first reporting goes back, I think, to 2009. So it has a very longitudinal view, which enables trend charts to be done. Trend charts are very important when you're looking at things, because when you're talking about small numbers, there can be month to month, year to year variation. Trend charts smooth that out so that you can see whether or not there's actually a real change or it's just fluctuation. So they produce trend charts. They produce trend charts in terms of numbers of such incidents, deaths, but they also produce trend charts in terms of rates. Clearly, the same number of deaths, if you're seeing a lot more people, is a reduction in the rate. So, you know, the rate is not necessarily the same as the number.
And you say nationally, rates of serious untowards incidents, including deaths, did not significantly rise over the same period. Am I right that when considering that what they consider is those who've been in contact with mental health services. Is that right?
So NKISH do two types of commentary in their reports. One is the general population one, and one is those who've been in contact with mental health services. They define contact with mental health services as contact in the last 12 months.
So just focusing on that contact with mental health services, so you're saying those rates didn't increase?
No, I'm saying those rates have not significantly increased, and they
Yes.
do fluctuate. They are still well below the rates for, say, 1980. They have slightly upped in the last few years, but if you, in terms of statistical process charts, which is a way of looking at whether or not there is a significant trend, they would fall within a sort of mean that suggested they were fluctuating rather than was a necessary trend. But only time will tell whether that will continue. So overall, the position would be they've been relatively static for the last 20 years.
And
They went to the lowest level about 2009-10. That was historically the lowest level, but they're slightly up from there.
and some might suggest the NKISH data underestimates harm from mental health, or harm experienced by mental health patients. What would your response to that be?
Clearly, harm comes in multiple forms. Being miserably unhappy, not being able to cope, self-neglect, all sorts of things come as harms from untreated or ineffectively treated mental disorder. They are only capturing things like death, which is only one aspect of harms.
So just limited in terms of what we can tell from that data, and again, not helped by the lack of outcome reporting data in the relevant period.
Yes, and that's why suicides and homicides are not a good single measure of the quality of mental health services.
I want to move on now, please, to section 2 of your report, and you deal there with mental health, severe mental illness, as one of the main inpatient service types. The first thing which you identify at the start is that 2.2 says controversy as to whether mental illness does exist and whether, or even if it exists, whether it's right to treat it. But the broader consensus which you identify is that it does exist and it can have a significant impact on people's health and functioning.
Yes.
And you also say that to some extent they can be addressed and mitigated by care and treatment. Is that right?
That's correct.
For the purposes of your report, am I right then that you deal with principles and practice which apply to those who've subscribed to that view that there is such a thing and you can treat it?
Yes.
At 2.4, you set out there some of the categorisation of mental health conditions, and it's right. There are two main categories: DSM, Diagnostic and Statistical Manual, which is a USA-based system. Is that right?
Correct.
And more commonly used in the NHS is the International Classification of Diseases, or the ICD.
Which is from the World Health Organization, yes.
And you refer in your report to their non-standard labels such as complex emotional needs. So am I right, those aren't included and defined within the DSM and ICD?
So some terms which start off as being not in there, get in there in revisions. Other terms don't. But the point I was trying to make there is that a lot of terms that you might read in notes, and I'm not referring to any specific case or notes here, but you will find terms in there that you would find it very difficult to track it back to either DSM-5 or to ICD-10, which was the most common one. And that has the big disadvantage that people can't then go and check whether or not they think that applies to them or to their relative, because there is no defined definition of that. So it's the lack of definition which is the issue. We also know that sometimes labels were used, for example, personality disorder was often used without it being linked back to a proper diagnostic set of criteria, even though there may be diagnostic criteria in one of those things.
And one of the things which you identify in your report, 2.5, is the fear of labelling, and you say that led to a trend through the 21st century of trying to avoid making clear diagnoses, and you identify that that is controversial, is that right?
Yes.
And you point out that for NHS-funded services, you will normally need to give and share a diagnosis, is that right?
Yes.
And you also, against the lack of labelling, you say that the need for clarity also falls within the general principle of nothing about me without me. So the point about being open and clear with a person about any diagnosis, is that right?
That's correct.
So you would be a supporter of offering a diagnosis, is that right?
I would, with the caveats that a diagnosis does not define each individual person, it's a broad category.
And can I just get a feeling for how prevalent your view is within the profession?
I think within the broader professions, because mental health is made up of multiple professions, I think the broader consensus is it's right to give people a clarity, and a diagnostic label can be very helpful. There are some people who don't think it is helpful because it can lead to people believing that that's labelled them for life. So there is controversy, but the majority would believe, and the NHS mental health service data set, which is what we're all required to complete, it's not always completed, in that you are meant to put in a diagnosis, and that should be a diagnosis in ICD-10 currently. So if you're going to put it in there, you should at least be sharing that with the person.
I understand. So the system, the NHS, the system is asking you to put in the diagnosis, and your point is, if you have to put it in the system, you should then share that with the individual.
Yes.
At 2.7, you deal with the term severe mental illness, and you point out, or SMI
Yes.
for short, and you point out that has fluctuated in meaning, and you describe that you use that term in the report in the same way as set out in the long-term plan, i.e. based by severity, not by diagnostic exclusion criteria. Can you just explain what you mean by that, please?
So in what was called QOF, which was the Quality Outcomes Framework for Primary Care, there was a definition for GPs to have a register of SMI, which was primarily based upon psychoses and bipolar affective disorder. That's one more narrow one. The one in the long-term plan is more inclusive than that. So if you've got very severe depression, very severe obsessive compulsive disorder, very severe anything, you would fall within the definition of severity. Whereas the older definitions, or some of the older definitions, would exclude you on the basis that your particular diagnostic label didn't fit, and that's not a good approach.
And you go on to define within your report 2.12 a mental disorder, and that is, according to the World Health Organization, defined as a mental disorder characterised by clinically significant disturbance in an individual's cognition, emotional regulation or behaviour. It is usually associated with distress or impairment in important areas of functioning.
Yes.
And you point out that the term SMI, or severe mental illness, is a term used to capture a group of mental disorders which are the most disabling. Is that right?
Yes.
And you describe those as a group of relapsing, remitting illnesses which cause a severe impact on the person's life and functioning.
Yes.
And they carry significant risks of chronic disability and premature mortality.
Yes.
And you point out much of this is preventable by early treatment back to remission.
Yes.
and also by rapid relapse intervention when early relapse signs occur.
And plans to reduce the frequency of relapse as well as, but there are three components. So early treatment, relapse prevention as far as possible, and early intervention in relapse if it does start.
And set against that objective, you point out that in the 21st century, a model of care developed focusing on crisis intervention, and you say that meant mental health services often waited too long until a person was in crisis, rather than working with people to intervene before an episode deteriorated to crisis point.
I do. I want to make it clear that was not the national intent. It's the way that the world developed. But if you focus on seeing people in crisis, then there are real examples around the country of people trying to get help and being told you're not in crisis yet, so we can't help you. So it inadvertently led to crisis being seen as a key criteria for access, which I'm saying in my report is too late in my opinion.
And you very much emphasise the need for early treatment and intervention.
Yes.
Can you just explain in a bit more detail why that is so important, please?
Every time that someone relapses, it's very traumatic for them, it's very traumatic for their family, it's very traumatic for people who care about them. The longer that you're in relapse for any condition, whether this is cancer or anything else, or diabetes or anything else, this is general, the longer that you're in a relapse state without being effectively treated, the more likelihood that secondary and tertiary harms and disabilities will occur. That makes the treatment more difficult. It also means that getting you back to your normal activities is more difficult. In terms of severe mental illness, if you have, for example, got to the point where you've been acting out inappropriately in the street or threatening neighbours, even when you've reduced that relapse back to remission, the person still has to deal with the consequences of what they were doing during that relapse. So the longer the relapse goes on, the more harms and disabilities and social consequences are attached to it, as well as the prolonged trauma and disruption to your life. If you're ill for a day or two, you can quickly get back to work. If you're very unwell for weeks or months, getting back into work is much more difficult. So it's at all levels of social interaction.
And you deal in your report with the fact that it's a very small proportion of those in contact with mental health services who become inpatients.
Yes.
I believe the figure you give is 2.4%, is that right?
That's from the national data, yes.
And you note in your report that the mainstay of care and treatment, in fact, is community-based, is that right?
And has been throughout the period I've been working in mental health, yes.
So it's important to understand that mental health inpatient care is a small but very important aspect of a much bigger, wider system.
It's an intensive, necessary top-up for some people, for some stage of their illness, yes.
And so when we look at mental health inpatient care, we need to look at it in the context of treatment, potentially in the community before and potentially after.
Yes.
You refer at 2.16 to the new teams which were brought in post the NSF, and you described that there were new resources but that they weren't fully funded. And you describe how new teams were better resourced than core services, with typically more funding per case, less turnover per year, and strong boundaries. Just pausing there, the term boundaries, strong boundaries, what do you mean by that? Is that geographical or is that boundaries of acceptance?
Primarily boundary acceptance. There will be some geographical in it as well, but it's primarily boundary acceptance. Tertiary teams can decline referrals from secondary teams. Now, secondary teams can decline referrals from general practice, but each time you've got that sort of thing, there will be there is the potential for disagreement as to who needs what. But also, tertiary teams were able to say, no, we have reached our capacity, whereas that was much more difficult for secondary teams to do that because they were having the influx of referrals from primary care continually. And to make room to see those new people, they either had to discharge people or to move them somewhere else.
So describing tertiary teams with being perhaps slightly firmer at accepting or not. You refer to secondary teams. Who do you mean by secondary teams?
That's where I'm talking about the core community teams, whatever they were called during that period.
So the community mental health team.
Yes.
And you say that the hope was that the new teams would take more work from the core teams. That hasn't been the case, as the bulk of increased demand has gone to the core teams, resulting in increasing wait times to be seen and faster discharges to keep within funding.
Yeah, so I'm not saying that the new teams didn't take cases, they clearly did. What I'm
Yes.
saying is that they weren't keeping pace with the increasing demand. So the overall effect was that the core teams had more demand than was being taken away by the new teams.
And you then say this further reduced time and resources per case, resulting in care and treatment being more stretched. And you say coupled with failures in NHS workplace planning in the 21st century, that led to more chronic vacancies, compassion fatigue, and burnout.
Yes.
Just pausing there and dealing with compassion fatigue. Just firstly, what do you mean by compassion fatigue?
Every human being has got a limited ability to be compassionate and empathic. The more we are stressed, the more, as individual human beings, the more we are rushed off our feet, the less time you have to think or to provide a compassionate response. You are trying just to do things, get from one job to the next, not having time to think about it. Particularly when you're talking about community and acute service, core community and acute services, there is high turnover. You know, if you're doing a clinic, you might be seeing 10 people for 15 minutes each. You have to be able to devote 15 minutes to one person, shut your mind down, go on to the next person, shut your mind down, go on to the next person. If you're being overstretched and you're being asked and you're having interruptions and being asked to do 4 or 5 different tasks at the same time, your ability to have that clear focus on each person goes down. If you're tired and exhausted because you've been doing extra shifts or covering overtime, you are less likely to be able to do that. You are more likely to be personally stressed. When we're personally stressed, we don't think as well, we make more mistakes. So it's a combination of all those things. That's not the only factors that led to compassion fatigue. Things like the feeling that no matter what you did, you were going to be wrong, and other types of factors like that also played into that.
So that was going to be my very
Sorry.
next question.
Sorry.
So staffing and resources is obviously a significant part of compassion fatigue, but just to summarise, you've also described the fear of getting things wrong as potentially being part of it. Can you just explain a bit more how that feeds, well, firstly, what you mean by that, and secondly, how that feeds into compassion fatigue?
Yeah. So I'm talking generalisations here. Just need to be clear about that. But in general, over the course of the last 25 or so years, a culture of fear has developed in mental health. And the fear is that no matter what you do, you're going to get blamed. So if you do something, you'll get blamed. If you don't do something, you'll get blamed. And just to take an example, if you're sitting on a community mental health team and there are 50 people waiting to be seen, if you go above 4-week waiting for that, then the team gets told off for 2 long waits. In order to see more people, you then have to discharge more people, but if you discharge someone and something goes wrong, you get blamed for that. If you don't discharge people and try and increase your caseload, then your time per case goes down. So if then something happens because someone didn't get a visit for several weeks, you get blamed for that. So a culture built up that no matter what you did, you were going to be in the wrong anyway. And that created the culture of fear, and it created a lot of defensive practice. So writing notes to try and explain that it wasn't your fault.
Can I go back to compassion fatigue? And you
Yes.
spoke about, in a sense, the stress that a staff
Yes.
member will be under,
Yes.
having to do too many
Yes.
roles in a too short space of time. One thing you didn't talk about was how that might appear to the person you're speaking with, and in particular, whether or not an element of that will also perhaps be appear as a sort of lack of kindness, a lack of empathy.
Yes, that's precisely what I was trying to convey. For the person or the family, they may see someone who's rushing, still appears to be thinking about the previous case, still appears to be thinking, oh, I've got 5 more people to see, I've got to rush this one through, doesn't appear to be fully engaging with you, they seem to be distracted by something else. So it comes out in multiple ways, and that tends to undermine trust, that tends to undermine therapeutic relationships.
Thank you.
Thank you. You've touched upon the impact of the new teams, and you've explained about the funding, and you've just explained about the impact of compassion fatigue. You also say in your report that there's now a general consensus that fragmentation and discontinuity of care and treatment has gone too far, even if there's less agreement about how to correct it. So when you say consensus, is that within the profession or is that more broadly?
I think it's more broadly, but it's certainly within the NHS. There's a recognition that there are a lot of teams. Each team is a new set of handovers. A lot of staff are spending time filling in referral forms and doing repeat assessments, which are not value-adding by and large. And they're also very frustrating for people and their families to get asked the same questions over and over again. Every time you have to go to see someone new, this can be actually very traumatizing because you're taking back through things in your life that you may have dealt with, but they're suddenly reopened because someone asked you all the same questions. So there's a recognition that the system is not working effectively. In the NICE lecture that you got, I saw a reference to up to 13 teams in one patch. Clearly, if you've got that number of teams, I'm familiar with smaller numbers than that, but still very large numbers of teams. And then people aren't sure which team you should be under. People aren't sure what are the criteria. People can get stuck between teams. You can have 3 or 4 teams arguing it's not us. And that's difficult for the teams, but as you can imagine, that's extremely difficult for the patient and the family to be told that you need something, but everyone says you need it, but not from us. That's extremely frustrating. And it tends to mean that you're not getting treatment, which means, going back to all the other things we talked about earlier, delays in treatment leading to more harms. And
you refer now to a move to pilot 6 pilots in England to see if a neighbourhood model can be better delivered again. Just in summary, what is it that is piloting now by way of comparison to what you've described previously?
So it's really important. When no one is talking about going back to the one-team model in the 1980s, we have got so much more information now, so much more opportunities to do things, that no single practitioner or team can know everything. But the aim of those teams is that you will stay with one team, but expertise will be brought in from other teams, rather than you will leave this team to go to that team, and then if that team don't think you're right, you will leave that team to go to another team. So it's trying to move to you having a core team that works with you and brings in expertise rather than you are transferred from one team to another. They're pilots. We do not know whether or not that's going to work.
Moving on now, if I can please, to the final area within section 2. I want to ask you about co-occurring conditions, and perhaps after that it might be a convenient moment, Chair, for a break. You deal with that from your paragraph 2.25, and you say that co-occurring conditions are more common and frequent than those, or in those with severe mental illness. And you describe those including physical conditions, but also mental conditions such as neurodiversity, learning disability, or substance misuse. Can I just start, please? Can you just define, please, what you mean by co-occurring?
So a co-occurring disorder is not the one that's the primary reason for you being in contact with that service. So, for example, if someone was coming to a mental health service, an early intervention psychosis service with psychosis, they might also have diabetes. They might also have rheumatoid arthritis. So You're not coming to the EIP team for treatment of those. They're not specialists in those. You are getting treatment for those elsewhere. But they have to take into account that you've got those conditions.
And just at a high level, to what extent can and do those affect, so those co-occurring conditions affect prognosis for someone with a mental health condition?
In general, in healthcare, the more co-occurring conditions you've got, the less good is your overall prognosis. That's a general thing. It doesn't just apply to mental health, it applies to any type of co-occurring condition. This is because the treatments for one may interfere with the treatments for another. It is that having one may actually make it more difficult for you to be able to deal with the necessary help and support for another one. That's a general thing. So in general, the trend would be that the more co-occurring conditions you've got, in general, the poorer the prognosis. That does not mean your prognosis is hopeless. It does not mean that lots can't be done. But in general, the prognosis is poorer. Therefore, you have to be thinking much more carefully about how you do manage the various different components. Where I refer to not interfering with other things, what we know, and for example, Gerf did work on surgery and diabetes. What we know is that if you've got people that aren't experts trying to adjust treatments on which they're not expert, that tends to cause more harm. So if you've got some of the current conditions, you may actually have to have lots of consultations with other people, but how much depends on the severity and the nature of the impact. I'm talking in very broad generalisations here.
So perhaps just to summarise, it increases complexity and it also increases the importance of coordination of care.
Yes.
And you also say in your report that the key point to note is that co-occurring conditions should not exclude people from mental health, learning disability and autism services, MHLDA services, where they have a condition requiring input from those services. And you make the point there'll be typically a need to take into account those conditions, and you described that. You refer to situations where people are excluded by virtue of a co-occurring condition. Can you just give an example of when that might happen?
There will be multiple examples, but just one example. If someone's got an alcohol or drug problem, they can be told that until you sort the alcohol and drug problem out, we can't deal with your mental health problem. They will then go to a drug and alcohol service who will say, until you get your mental health sorted out, we can't deal with your drug and alcohol problem. I'm not saying that's common. There often are very good working relationships, but what I'm saying is that's an example of what can happen. Another example can be because you have got a personality disorder, we can't treat your other mental disorders. That is not true. Personality disorder is not a diagnosis of exclusion, but you will hear people being told that up and down the country over this time period that you're looking at.
And you emphasise the importance that in treating severe mental illness, there is a need to take account of and make reasonable adjustments for any co-occurring condition. Is that right?
Absolutely.
And can I just ask a very specific question on that? What role do care plans have in taking that into account, so taking into account co-occurring conditions?
The care plan clearly should reference that there are co-occurring conditions. If there are very significant things that need to be considered, they should be in the care plan. In terms of reasonable adjustments are person specific, but they're also situation and time specific. So you can't say something should be in a care plan to cover every eventuality, but you can say this is something that needs flagging up, you need to look at this if circumstances change.
And you describe that adjustments based on a co-occurring condition need to be reasonable. Can I just ask, can you give an example of what reasonable adjustment might look like in a particular patient with a co-occurring condition, what reasonable might be?
At the simplest level, one issue that particularly in older adult services, people used to complain about was people were being asked to read things, but their spectacles had been lost. And clearly, if you took away my spectacles, that's a reasonable adjustment I've lost and I'm struggling. Similarly with dentures, people, they haven't eaten the food, but no one could find the dentures. So at the very simplest level, it could be something as simple as that. Yeah. At a more complex level, it might be, for example, if someone's got a particular hypersensitivity to noise, it's how you can manage that in an acute ward, which is by nature going to have lots of disturbances and noise in it. There are going to be different people on that ward every day. Admissions might be occurring any time of the day. The person themselves might be actually making a lot of noise, which is distressing other people. So it's how you manage that. So sometimes they are simple to fix, and sometimes it's a matter of trying to balance what is reasonable against what's necessary. So, for example, if someone's got a needle phobia and they need a drip, then you've got to overcome that. You can't just say, because you've got a needle phobia, we won't give you a drip. So I'm slightly oversimplifying it there, but I'm trying to make a general point.
I understand. And perhaps just, I think you may have dealt with this already, but to summarise, you would perhaps also expect as a matter of good practice, those sort of reasonable adjustments ought to be recorded in things like care plans.
Where there are ones that are known to be generally applicable to that person, it would be ideal for that. There's also the opportunity in most electronic patient records to have a flagging alert system for that. So you can take account. What we would want people to do is to read and take account of that. You then have to decide how much of that is reasonable in the current circumstances, but it tells you that these are things you need to consider, and if you're not going to do them, why wouldn't you be doing them? If you think there's a better way of doing it, then that's a different thing. So it's not that they mandate what should be done, but they highlight things that need to be taken into account.
And I think it follows from your evidence, you've touched on already, but it would be good practice for those dealing with mental health inpatient care to work with others who are treating co-occurring conditions. There needs to be a degree of cooperation.
There does. I mean, how much depends on individual circumstances, but yes, as a principle, yes.
And also coordination as well.
Yes.
Thank you, Dr. Davis. That brings me to the end of that section of your report. Chair, if that's a convenient moment, perhaps we could take a break.
Yes. 10 minutes or 15? 15 minutes? 15 minutes. Good. Thank you.
Thank you, Chair. Dr Davidson, I want to continue and deal with a section of your report concerning inequities of access and service in mental health from your paragraph 2.30 onwards. And you highlight there the significant disparity in who is more likely to experience mental health problems and service access and prognosis. And this is a very large topic,
Yes.
and the first point to make is that you only touch upon this by way of introduction.
Yes.
And similarly, my questions are only going to touch upon this by way of introduction. At 2.31, you make the point that although there's large amounts of data available about who accesses services, that's rarely analysed and reported.
Yes.
So that's another limitation in what we know and what we can deduce. And at 2.32, you give an example of those overrepresented in the data as those of black ethnicity, particularly males, who are overrepresented in those detained under the Mental Health Act and those spending long periods in inpatient settings.
Yes.
You also set out there that it's becoming increasingly clear that those with neurodiversity, especially autism and ADHD, are overrepresented. Is that right?
Yes.
And again, I'm not going to deal with that in any detail now because that is a very large topic indeed.
Yes.
And the inquiry intends to deal with that in some detail in itself. But right to make clear that neurodiversity and ADHD are very much issues which the profession is becoming more alive to. Is that fair to say?
Yes.
And just one question on that, if I can, just to touch on. In outline, are you able to just identify some of the key reasons why those with neurodiversity tend to be overrepresented in inpatient admissions?
So in general, and in my GIRF report in 2021, I talked about marginalised and excluded groups. So it's a wide range of different types of groups. Specifically in relation to something like autism, at a very high level, autistic people often present atypically to what might be conventionally expected. So this can lead to misinterpretations, not just in mental health, but in physical health. So an autistic person might be in severe pain, but may have a smile on their face. Someone looking at them might think their pain can't be significant because they're smiling, but it doesn't necessarily link. So there are miscommunications that occur. There's also differential use of language. Autistic people tend to be, and I'm making sweeping generalizations here, tend to be more logical and precise in the use of language, whereas non-autistic people are often fast and loose with language. So autistic people will tend to use language the way they were taught at school, and correctly and grammatically, whereas non-autistic people will use a lot of loose language, which is very difficult for the autistic person to interpret. So communication issues don't go in one direction, communication issues go in both directions. Those things therefore make you more vulnerable at all stages of your life to misunderstandings and misinterpretations. They also, autistic people, on top of that, tend to have smaller social networks for a variety of reasons, which I won't go into here because it's too much detail. But if you've got smaller social networks, you are more vulnerable to things like bullying and abuse because you've got fewer people around you to protect you. You are also more vulnerable if bad things happen in your life for any reason. In all of our lives, bad things happen. If you've got a good social network around you, you've got that extra support, people to go to, people who give you advice. The smaller your social network, the less you've got to fall back on, so the more vulnerable you are to everyday stresses and strains. Everyday stresses and strains can of themselves, if they're sufficient in number and quantity, tip someone into becoming unwell, physically or mentally. So that's a very broad outline.
Thank you, and I'm sure you appreciate we're already touching on this. We are going to, as an inquiry, come back to it. You then deal in your report from paragraph 2.34 to the question of risk management. which I'm going to deal with now, but right to say that what you're referring to is risk management of those admitted as inpatients?
So in this particular context, I'm using risk management in a broader sense because the inquiry is also looking at people who are post-discharge, but in that sense of acute.
And I just want to ask some general questions about risk management at this stage, although I appreciate it's something which spans all of your report and the various different stages of inpatient care. My first question is this. In overview, what do you mean when you use the term risk management, as you do there in your report?
So I'm using it in the sense that it's become an abused term. People talk about, have you done a risk assessment? Have you risk managed? In safety-conscious industries, you don't use those terms in that way. You are looking at what are we trying to achieve, what are the risks associated with trying to achieve that, and how do we minimise unwarranted avoidable harms. In mental health, it's become, have you done a risk assessment? Have you done a risk management plan? But it doesn't define which types of things you're trying to do, and it doesn't define what benefits you're trying to achieve, and are those benefits worth it despite those harms. So, for example, to take a non-mental example, in cancer treatments will cause you harm. But the aim is that the benefits they will give you, for most people, but not for everyone, will outweigh the harm. The same in mental health. But what's become is risk management is like almost you can prevent any risk occurring. That's clearly impossible.
So just to refine that a little bit more, what you're really focused on is, you're saying there's obviously a difference between risk management in the broader sense and risk elimination.
And the two get conflated.
And your criticism, to be clear, is primarily directed at trying to eliminate risk, which in your view is simply unachievable.
That's one aspect. The other aspect is if you're not looking at what you're trying to achieve, you can't do the balance. So in order to achieve anything in life, you have to accept there are risks attached to it. And you have to weigh these. What I'm trying to get across is that the safest way to avoid motor traffic accidents would be to ban motor vehicles. There are huge consequences to ban motor vehicles. So, in safety-conscious industries, what you're looking at is what is the reasonable things that you can do in order to still achieve the purpose you're trying to do. So to treat someone, you are going to cause them harm with most of the treatments we do. As I say, some people will be harmed by any type of treatment, whether it's physical, psychological, pharmacological, or social. You can't say we will risk manage to the point where there is no harm. What you have to say is, does the benefit outweigh the harm? And if you focus purely on the risk management, you ignore, are we achieving the benefits? And if you don't achieve the benefits, the person is left in an ineffectively treated state.
And I'm going to come back to that in a bit more detail, but before I do, can I just ask this? You refer in your report to a move during the relevant period to a focus on risk management.
Yes.
And by that you mean the focus on filling in risk assessments, etc., rather than necessarily treatment. What was the cause of that, so far as you understand it?
This is a personal opinion. I can't verify this, but part of that was the sense that a lot of inquiries, a lot of both internal inquiries as well as external inquiries, a lot of regulation, they use very loose terms. So they say things like you will prevent or you will meet someone's needs, etc., rather than... So a problem was that for the practitioners, they were often faced with things that were focused on, did you complete the risk assessment form, rather than did you give good care and treatment. And obviously, if you know you're going to be marked on something, and if something goes wrong, your professional career will depend on that. You tend to put more focus on that which can end your career than on what... And that's a dilemma for people, because you go into the vast majority of people go into caring professions because they want to help people. I'm not saying there aren't some people who are not of that category, but the vast majority are. That's why you go in. But then if you know that something goes wrong, you're going to be marked on whether or not a document was completed. The document takes precedence over care and treatment.
I understand. So just sort of drawing some of that together, if I can, would it be right to say that you're not critical of risk management as part of a course of treatment, that you're critical of risk management in isolation, as it were.
Yes, and what we're trying to do, and you will see it's reflected in the stuff that you got from NICE, you will see it's reflected in other documents, we are trying now to move to people thinking in terms of a safety culture, which is actually balancing the therapeutic gains against the harms.
So does it follow then that if there's risk management as part of a holistic treatment plan addressing the underlying illness, treating the underlying illness, you wouldn't be critical of that? I strongly endorse that we should be trying to, as I say in my report, prevent or mitigate unwarranted avoidable harms. That therefore is a form of risk management, but it's a very focused form of risk management on what you can practically do while still achieving what you set out to do. And just perhaps following through to an example, one of the risks in treating someone with serious mental illness is the risk of relapse. That is something you would want to plan for,
Yes.
and that would be, in your view, an appropriate risk management measure, as opposed to simply a risk assessment.
Yes, with I know we're not going into detail. I don't want to go into too much detail, but we cannot prevent relapses. Many things in life can precipitate a relapse. The person can't prevent relapses. We can't. Some relapses are more preventable than others, but some just come out. You know, for example, COVID coming in devastates someone, tipped a lot of people into relapse. We couldn't know that was going to come. So in terms of this, that's why we're talking about relapse prevention and mitigation plans. So it's one, if we can reduce the things that are going to lead you into relapse, we should be working to do that. But there will be a whole variety of things that we can't control, but may tip you into relapse, and therefore we need to be able to rapidly recognise you're slipping into relapse and do something to support you in relapse, rather than pretending that we can stop all those risks happening.
And you also make reference in your report to the focus on risk management being recognised to have been an error. When you say recognised to have been an error, who are you referring to there? Is that the psychiatric profession, or is that healthcare more broadly?
Healthcare more broadly, and for example, you will see that in the NICE presentation you got, which is moving away from risk as... one of the other problems with focus on risk is that, like I said earlier, you might then reject someone because the perceived immediate risk isn't high enough now. And so, you know, you wait till something has gone wrong and then you intervene. So that focus on risk as the sole determinant rather than what you're trying to help the person to achieve is now widely recognised to have been an error.
I want to just ask about some of the factors influencing that move to risk management. And can I just explore whether some of these were at play? Would those factors include resourcing and staffing pressure? Would that be one of the reasons for the move to risk management?
They increase the risks because obviously if you haven't got the resources to deliver the therapeutic benefit, more harms are likely to occur. So I'm not saying that they of themselves drove a risk management focus, but they drove a very defensive focus because you knew that you couldn't do what was necessary. So you then had to try and define that in a way which would hopefully, as an individual, mean that if something did go wrong, you were less likely to be found at fault, which is not the right way to approach care and treatment.
And would you say that fragmentation and discontinuity of care was also a factor?
Yes, because again, they introduce a lot more risks and a lot more variables, and the aim of a lot of the forms was to try and show that things have been looked at, but the problem with multiple forms is no one's got time to fill them in properly and no one's got time to read them properly. So they give an illusion of managing risk, but they actually increase risks if they're too complex and too long.
Now I'm going to just pause there, Dr. Davidson, because it's now 11:59 and we are going to be observing a 2-minute silence at 12. So I'm going to pause my questioning at that point.
Thank you.
Can I ask everybody to stand for 2 minutes?
So apologies. Can I just add something extra?
Yes, please
Very,
do.
very, very brief. One of the other consequences of a risk management approach is that one of the ways of managing risk to yourself or your team or your service or your trust or whatever is to decline to accept people because you define them as being too risky, or to decline to do things that may be necessary because they carry a risk that there may be adverse consequences. So it led to people being excluded from services as well.
So just still on those factors driving that approach, I think you've dealt with staffing, you've dealt with discontinuity, you've dealt with also acceptance. What, if any, other factors would you say were also driving that risk management focus?
Fear. The fear of staff that they would get blamed for something that went wrong.
Now, you also deal with, in your report and generally, assessment of risk. And can I ask you, on a more practical basis, but how reliable were the tools in the relevant period for actually assessing risk? How reliable or how helpful are those?
So most of the indicators are actually useful at a population level. So, for example, if you're looking at suicide, males from 25 years upwards are much more likely to die by suicide. That doesn't help you at an individual level as to whether this particular male who is 30 is likely to die by suicide or not. So an awful lot of the things that are there are things that work at the population level but are not of much use at the. And for example, having serious mental illness is a risk factor for serious untoward events, but everyone that you'll be seeing has got a serious mental illness. So a lot of them at population level, at public health population level, they're really important for identifying things that you can do to reduce the population risk of suicide. But a lot of them are homicide. A lot of them are not modifiable by a mental health team. And a lot of them don't help you when you're faced with an individual in knowing whether that person's got a lifetime likelihood of doing it, and even if they have a lifetime increased probability, what does that mean in practical terms in the next day, 2 days, week, month, or whatever?
So perhaps just to summarise, that the sort of risk management tools which a practitioner has, would it be right to say, are not particularly effective in accurately predicting risk?
All the evidence, including from mean cases, that many people who end up dying are regarded using those tools as low risk, yes.
And the best thing a practitioner can do is to focus on delivering the therapeutic care to address the underlying illness.
Yes, so one of the key roles of staff in mental health is holding hope for people. People tend to die by suicide when they've lost hope. So one of our key roles is keeping hope. It's not falsely reassuring people, but it's saying there are things that can be done to help. We will work with you to help with that. We will explore with you what are the best ways of trying to help with that. And if the first thing we try doesn't work, there are other things we can try. Unfortunately, at times people were told you need this or you must have this, and then if it didn't work, it actually made them more suicidal because they thought, oh, that just confirms I've no future. So language is very important in this, but yes, absolutely, a key bit of this is holding hope for people by working with them to explore what options there are that might work for them.
And can you explain by way of example, perhaps, why a focus on risk management rather than treatment, in your view, is unworkable?
To take an example for an inpatient, you can try and risk manage someone's risk of harm by high levels of observation. That will suppress the behaviour, but won't alter the reasons why that behaviour exists. So if you're not actually altering the reasons why the behaviour exists, as soon as a gap appears, so someone doesn't do the observation when they're meant to, or the person gets leave, or the person's discharged, those behaviours which have been suppressed just come out again. So you can suppress unwanted behaviours by things like high levels of observation, by high levels of supervision, by very restricted practices, but suppressing it is not the same as addressing it.
And finally, Dr. Evans, in relation to that risk management question, at this stage it will come up again in different areas, but is there anything in your view which still needs to be done from from a practitioner's perspective to rebalance the focus between therapeutic care and risk management?
There is work ongoing. That's why increasingly NICE and everyone else is talking about safety plans. That's why we're trying to move away from talking about crisis plans to safety plans. So there is a lot to do. You're changing a culture that's built up over 25 years. We have to change that culture. We have to work with people doing investigations locally and nationally. That's why the I can't remember what it stands for, PSIRF has come in, patient safety, whatever, it's in my report, sorry. But the focus is moving more and more to how we actually focus on, are we achieving what we need to achieve in the way which is least harmful?
And just pausing you there, Dr. Davidson, I'm aware, Ms. Nelligan, I haven't asked you many questions at this stage. You also deal with this in your report. But can I just ask at this stage, in broad terms, do you agree with Dr. Davidson's evidence in respect of the need for approach on therapeutic care over risk management?
I do.
And is there anything you want to add at this stage from a nursing perspective on that point?
No.
Moving on then, please, in your report, Dr. Davidson, you deal with next at 2.37. You say where staff are overstretched, you've referred to this already, it will impact the quality of their decision making. And you say it's particularly marked where staff are coping with long-term vacancies. You say the test remains, was the decision a reasonable one in the circumstances? And if not, what factors contributed to that decision by the person and from the system? So just finishing off that section of your report, is it right to say when we look at care, you need to look very much at the system as much, if not more, than the individual?
Yes.
I want to move on to the third section of your report where you deal with assessment that could give rise to admission. And after that, I hope to move to Ms. Nelligan to deal with some of the practicalities of what happens when someone is admitted. And I'm hoping that we'll get to that before lunch, if possible.
Sorry, can I just ask one very quick question? I missed what you were saying about supervision, high levels of observations, suppressing unwarranted, unwelcome behaviours, which will only reassert themselves when all of that stops. Are you also saying that that in itself might increase the behaviours, the issues that are being dealt with?
There is little doubt that if you stop some types of behaviours, people will find other ways of trying to release that stress and frustration.
Yes.
So, for example, if you stop people, say, cutting themselves,
Yes.
they may end up headbanging on a wall. Cutting yourself is very unlikely to cause you to die. Headbanging can kill you the first time you do it.
Thank you. And we'll come back in due course to things like observations and other forms of what might be termed restrictive practice. Turning then to assessment that could give rise to admission, you start that section of your report by saying, well, in fact, perhaps before I go into that, it's right firstly to say that whilst general principles apply, the criteria for admission to any inpatient unit will vary very significantly depending on the type and the ward. Is that right?
Yes.
And in your report, you deal with this at a high level in overview.
Yes.
The first point you make at 3.1 is that each and every clinical contact contains within it the possibility that mental health admission might be necessary. When you say clinical contact, how broadly are you referring to there? Is that any contact with any clinician or just with a mental health clinician? What do you mean by that?
So I think this is where the issue of assessment versus decision making comes in. Many people contribute to an assessment. A family member might contribute to an assessment, a support worker, a homeless worker. So an assessment is pulling together information. In terms of when I'm talking about clinical contact, it's therefore to some clinician who is going to be making a decision, information has come to light. That could be from me bumping into someone. For an example, I could be visiting someone in a supported accommodation, and whilst I'm there, I notice that someone else who's a patient of mine is not looking right. And I might then go and have a conversation with them to say, are you all right? So it can be as opportunistic as that. So people tend to think of assessments as being sort of like a big interview, whereas in fact it's a continual process. You know, on an inpatient ward, and Maria can deal with this much better than me, but in an inpatient ward, nurses are looking at people all through the day. If someone's not looking right, you would probably go and have a conversation with them and say, what's going on? That of itself is an assessment. I know it's not about admission, but similarly in the community, people, and it has happened, people might say, you know, from another team, I saw someone that you deal with down at the shops and they weren't looking right, perhaps someone might need to go and see them. That's part of the assessment. So assessment's a very, very broad term.
And you refer to the breadth there. I think that example is with you as perhaps a psychiatrist, but to give a complete different context, might a contact with GP or, for example, A&E also result in some form of assessment and referral?
Yes.
So it spans, in effect, the potential for assessment spans a very wide range of different healthcare contexts and scenarios.
Every healthcare contact and a lot of social care contacts contain within them an element of assessment.
And can you just help us? You've described a very informal process of assessment, bumping into somebody in the corridor. But can you help us as to give an example of how you might conduct a more formal assessment of somebody?
So, in terms of what might happen, so you might get a referral from a GP who says, can you see X for me? If it's not urgent, you would probably book them an outpatient appointment or a home visit. And you would probably, in most cases, set apart an hour aside for that. That was common during this period. During that hour, you would then be trying to elicit as much information as you could, either from what was in the referral letter, from what other sources of information. So if the person was already known to services, you would have looked on the case records and more recently the electronic patient record to see what was already known. You would go and see the person. If there were informants with them, you would try and get information from informants as well. For some types of assessment, we would actually ask people to sort of bring an informant with them, or so it's quite variable, but essentially what you're trying to do is, in a relatively short period of time, pull together enough information to come up with a working plan.
So does that being the key point in any given situation, you need enough information for a plan, in effect?
Yeah, in acute, you're often scrambling, you know, so if you're asked to see someone, for example, a homeless worker, when I worked in homeless teams, they may know nothing about the person. There may be no records on this person. You know, you may have a limited length of time the person's willing to talk to you. So you're making the best use of what is available, rather than there's an ideal that must be available, otherwise you won't do an assessment. Otherwise you would not see an awful lot of people who need assessing. And
you say in your report that the key questions in every assessment are why this person, in this particular way, at this particular time.
Yes.
So that would be presumably a principle spanning any, in effect, all assessments.
Yes. Because each person's unique, and if you're going to do person-centred care, it has to be around that person.
And just clarifying who might carry out an assessment, am I right from your previous answers that could in effect be any healthcare professional?
it can be much broader than healthcare professionals. As I say, it might be a homeless worker. So people contribute to an assessment. That's not the same as necessarily them being the final decision maker about whether admission is necessary, but lots of people contribute to an assessment.
So it would be
Or
wrong.
potentially can do, yeah.
It would be wrong for us to think about assessment in a rigid, narrow way of a psychiatrist sat in a room going through lots of questions with an individual. It's much broader than that, and that psychiatrist may do that, but they rely on information from a number of others, and it's not a static process.
Yes, it's a very mobile and varied process.
You say at 3.4 that during the relevant period, admissions to acute adult and older wards should have been made by the intensive home treatment team. We touched on this earlier, but can you just explain why you say that?
So the purpose of the intensive home treatment team is, as I say, to make sure that the person can't receive treatment and current treatment as effectively in the community as they can do in hospital. If they can receive it in the community, it's generally going to be much better to receive it in the community. You don't have all the distress of having to go into a ward with lots of other people. You don't have the dislocation from the things you're familiar with. So in general, the preference is to treat people at home if possible. The home treatment team are the people who are best equipped to know what's actually practically available in that local area at that particular time. It's all very well, in theory, a whole range of things might be available. They know what is practically available. They also know, for example, given the staffing shortages, if you've got a home treatment team that should be able to do 3 visits a day, but is so short of staff they can only do 1 visit a day, the threshold for admission will change. So they are the best people to judge what's reasonably available at that time in that local area.
And again, just in summary, what type of benefit not available in the community tends to favour an inpatient admission, so something you can only get from being an inpatient?
So an inpatient stay is a huge increase in input. You are getting 24/7 skilled nursing care. I know there are issues about how much nursing care is available on wards, but you are getting that. You very rarely in the community will be getting 24/7 anything. If it is anything, it may be from a care worker in supported accommodation, whatever. I'm not knocking that. Those are extremely valuable, but it's not the same as 24/7 specialist nursing care. Like I say, a home treatment team, a general community team might be able to see you once every fortnight. They can, for a short period of time, possibly step that up to several times in a week, but they can't sustain that, because if they do sustain that, then they're not seeing new referrals, etc. So the home treatment team is meant to come in and provide, crisis home treatment team, come in and provide extra support, but their support will typically be of a number of visits per day rather than 24/7. So the intensity of support you need is one factor. The ability to deliver that care practically in your home environment is another. So for example, like I said, a lot of places wouldn't do clozapine titration at home. So there are practical things like that, but there's also obviously the fact that whether or not you're able and willing to consent to that treatment at home, whether or not, even if you're willing to consent to that treatment at home, you're practically able to cooperate with that treatment at home. For example, if you don't have a stable home environment, it may theoretically be possible to treat you at home, but it may actually be practically very difficult. So it tends to be, what is it that you can't do, and can we do that better in hospital?
And would one of the factors there also be the fact that in an inpatient unit there is a greater degree of control over the environment?
Absolutely. So like I say, you've got 24/7 nursing care, which means that if you are at a position where you might be likely to harm yourself or harm someone else, there is a lot more support to try and work out with you ways of not doing that, right through to at the extreme, including things like restraint, which are not feasible at home. So it's much more intensive, and therefore the issue is, can you manage it at home? And if you can't manage it at home, do you need the more intensive support that an inpatient unit will offer?
And at 3.10 of your report, you say the purpose of admission is getting necessary care and treatment to bring the person back as quickly as possible to sufficient remission to allow community care and treatment.
Yes.
And in doing that, you're seeking the maximum therapeutic benefit from the admission.
Yes.
and that in turn is likely to prevent or mitigate unwarranted or avoidable harm. You also say in your report that admission is not a neutral act.
Yes.
And you highlight that there are potential harms associated with admission.
Yes.
Again, just very briefly, can you just set out what some of those potential harms would be?
In very general terms, there is the immediate dislocation from your normal support services, etc., your normal things that comfort you, your own bedroom, that sort of thing. So that tends to make people's mental state a bit worse. There are things like there are other people on the ward who've got their own problems, and sometimes they can be loud or aggressive or can actually try and attack you. You can get robbed on the ward. You are more likely to get, for example, in the COVID example, but it happens all the time, infections are more likely to occur in wards than in the community because you're in more close proximity with people. So if someone's got the flu or some other condition, you're more likely to get it. The longer you're in a ward, the more de-skilled you become. And therefore getting back into the community gets harder. You're also dislocated, so you've got more explaining to do when you go back, which is quite stressful for a lot of people. So one of the problems in mental health was people often talked about things like, we will admit you to the ward to keep you safe, and that's just not true. We will admit you to the ward because it's necessary, and we will try and make it as safe as possible, but it is not a safe place to admit someone to.
You go on in your report to highlight some of the difficulties that practitioners face in balancing therapeutic care and also risks to patients. And some of the challenges you identify, again, looking at 3.11, is in the early part of the 21st century, the fact that most mental health records were handwritten. Is that right?
Yes.
The result of that meant that community notes from a patient would often not be accessible if that patient was admitted as an inpatient. Is that right?
It wasn't infrequent. I wouldn't say how common it was, but it was a distinct and known problem.
You also highlight the difficulty with mental health services generally being 9 to 5 and out of hours, individuals tending to be seen by a unit like A&E, and that also had the disadvantage they wouldn't have any prior knowledge of the individual.
Yes.
And presumably, again, the issue, if there were handwritten patient notes, they wouldn't have access to those.
Obviously, for some people who might be return attenders, they may have something, but in general, yes, that's correct.
And given those difficulties, would you agree that the family or carers of a patient should also have been seen as a key source of information?
Families and key others are always a key source of information if it's practically available.
And it would follow, presumably, that given limits to patient records, it would always be good practice to seek information from the family as far as possible.
As far as reasonably practical, yes.
And can you just explain why that's so important?
When any of us is in crisis, we are not in a good position to describe our life. When you're in crisis, you are not thinking very straight. Your priority is just get out of this. You've got very high adrenaline levels. So people are not good at giving a proper balanced view of themselves when they're in a crisis. It's very difficult for them to. Our memory is mood dependent, so if we're in a very distressed state, we will tend to give a history of our lives which is full of distress and not reflect other things. So it can be very difficult to understand what the person's normal baseline is and how much this is a variance from the normal baseline when they're in distress. The family might say, this is not very dissimilar to the normal baseline, or this is radically different to the normal baseline and we've never seen them like this before. So they can give you a lot of context. I am not saying that you would necessarily, in all cases, that the family can do that. I'm not saying in all circumstances that the family has got an accurate picture of that, because not everyone shares everything with their family, but they are a very important source of information.
And this is touched on later in the report, and I also appreciate that this is a very complex issue that we're not going to be able to go into any detail, but generally speaking, is there any confidentiality issue or prohibition which prevents practitioners seeking information from families or relatives, even if the person being treated doesn't consent to information being shared about their care?
So if the people don't know the person's there may be confidentiality issues. For example, the fact that someone's on a ward, they may not want even the family to know they're on a ward. So there can be, but too often, historically, people would cite confidentiality. In general, there is much less limitation on you listening to someone because you're not sharing anything confidential but there may be certain circumstances where even telling them the person's in the ward is breaching confidentiality. But in general, listening to someone is something that you can do. And I think you might go on later, but in terms of Caldecott rules, they were brought in the 1990s and then strengthened in the 2000s because staff were often misunderstanding confidentiality and thinking that they couldn't do things when in fact they could. So a lot of guidance has been brought in that, but it's still too commonly misunderstood.
So to give perhaps a very simple example, say the family member is fully aware that someone has been admitted as an inpatient, they know they're there, they perhaps ring up or visit, nothing in terms of the rules of confidentiality to prevent someone, practitioner from that ward or unit or healthcare professional from asking for information from that family member.
So a key test there is it already in the public domain? And so if the people already know it, it's in the public domain. So you're not breaching that's no longer confidential. The same, with anything, the test is this confidential or not? If it's in the public domain, it's not confidential. So if a family said, can you tell us about the likely prognosis for, say, schizophrenia? That's in the public domain. That's not about anything confidential about the individual. So there are things you can discuss with people without breaching confidentiality, even if someone said, I don't want you to discuss anything confidential.
And so perhaps just to summarise, would you agree then perhaps room for improvement in terms of seeking information from family members dealing with inpatient care?
If you look at NHS IT training, which we all have to annually, it's very much about don't. And it's about protecting organisations from reputational damage by stuff leaking. There's much less emphasis on do. The Caldecott rules do try to balance that by setting it up, but the training that we get, the national requirement to do your annual training tends to focus very much on don't rather than do.
Just moving on in your report 3.12, where you deal with the advent of electronic patient records. That obviously improved the situation in terms of making access quicker to patient records. You highlight that there are still challenges with lots of information on the system, some of that not being easily accessible to those who needed it. And you make the point in your report that often there would be an incident after which those investigating would be able to find information on the system, but that information wasn't necessarily available to those at the time. Is that right?
Yeah.
And just following on from that, would you suggest that there is still a need to rework electronic patient records to make information more easily accessible to practitioners?
Yes, so just in terms of that, back in the 1980s, the problem was we had lack of access to information. Now, by and large, we've got information overload. And trying to find the key stuff amongst all the masses of forms and everything else is extremely difficult. So one of the issues with EPRs and mental health is they're very good at collecting forms and data. They are not so good at what we would call supporting clinicians in making critical decisions. So it's about how we make sure the right information is available to the clinician when they need it. If you've got 15 minutes to assess someone and make a decision and come up with a working plan, you can't be going through hundreds and hundreds of forms.
You go on in this section at 3.13 to set out that through the 21st century, Some people were admitted when it might not have been the best option, perhaps reflecting some of the disadvantages you just told us about, but others were not admitted at the optimum time when they would have been or should have been had the relevant facts been known to the decision maker.
Yes.
At 3.14, you go on to set out their pressures not to admit for non-clinical reasons and a culture of admission as a last resort developing, where you say not universally, but too often this meant that by the time people were admitted, they'd passed the optimum point for admission and further harms and disabilities had occurred, leading to more complex needs, more use of the Mental Health Act. By that you mean the Mental Health Act in terms of the powers to detain someone,
Yes.
and increasing lengths of admission. Can I just ask this? What would be an example or a common example of a non-clinical reason for not admitting somebody in the relevant period?
So it goes back to the things that people are measured on. So regions, commissioners, trusts were measured on things like how many people you'd in an appropriate out-of-area bed. So if there was no bed available except an inappropriate out-of-area bed, people would say, well, we shouldn't admit to that because that will notch it up. There was a pressure to that. I'm not saying that would be the final decision, but there was an enormous pressure not to increase your use of beds away from your area. There were also financial consequences to using extra beds because they weren't in your budget. So that was a pressure. If you take learning disabilities and autism, one of their requirements was to reduce the number of admissions over a number of years. It wasn't measured on, are you improving the care for these people? It was measured on the number of admissions and reducing the number of admissions. And that's still a national priority for learning disability and autism, is to reduce the number of admissions, not to measure whether people are getting better care, because we don't measure outcomes. If you were reducing the admissions because you're delivering better outcomes, that's fine, no one's got a problem with that. If you just focus on reducing admissions, that's a non-clinical reason for not admitting.
So that's one example. You've also referred to the out-of-area bed use metric,
Yeah.
and you're critical of that as well, as not being helpful for judging delivery of treatment and care.
Not critical of the sense that we want to reduce out-of-area bed usage for the reasons we've said. I am critical that the metric is set on numbers of people in those beds rather than the more important metric, which is, do people get into a local bed when they need it? And that's my criticism of that.
So your preferred metric would be that, do people get into the bed when they need it?
Yeah. A local bed within 12 hours, as I say, would be my preferred metric, yes.
And does it follow that the problem would also be helped by better outcome data being used to measure rather than necessarily just focusing on beds?
Yes, and if we also focus more on occupied bed days rather than admission numbers, that would help as well.
You refer at 3.17 to the inappropriate out-of-area metric of beds, spawning a grey area of beds outside the local trust in other providers but considered appropriate, which helped keep down numbers deemed inappropriate. Grey beds there in the local area, are you referring there to private providers?
It can be private providers, it could also be other NHS organisations. So some trusts which at a particular time had a surplus of beds over their local needs might offer award to, or beds on award to another local trust. So it's not about which sector you're from, it's about you're not a bed in the local provider.
And at 3.19, you go on to describe that from 2019 onwards there were significant increases in delays getting into any mental health inpatient bed when essential.
Yep.
And you say that the delays caused by the increased time it would take to get to a point where an empty bed was available.
Yep.
Are you able to help us as to what was causing that delay in beds becoming available?
So there were two distinct factors in a broad sense. One is, as I said earlier, if you delay admissions, people tend to come in a worse state, so it takes longer for them to get to the point where they can go back to the community. There's more likelihood that their existing community support is broken down, so it could be more difficult to come up with an aftercare plan. So that's one. The other one is what are called clinic ready for discharge delays. So there are multiple of those, but for example, a common one is simply there is no accommodation for the person to go back to, so they no longer need to be in hospital, but for one reason or another, they no longer have accommodation in the community. And trying to find accommodation for the community can be very difficult and can be very lengthy because local authorities and housing providers are cash-strapped themselves, and there are often national shortages of this. It's not necessarily discrimination against people with mental health problems, it's just there is a simple shortage. But obviously there's a tendency to think, well, they're in a bed, so they're less priority than someone who isn't in a bed. So that caused a lot of problems. If you look at those who are waiting for beds, clinical ready for discharge delays in most parts of the country exceed the number waiting for beds on any given day.
So to summarise that very quickly, if you were more efficient at dealing with those who are inpatients, that would reduce delays to those waiting for beds.
Efficient's not the word I would use. Efficient is true in terms of getting them to the point where they're clinically ready for discharge, but no matter how efficient you are getting them clinically ready for discharge, if there's nowhere for them to go to, you can't do that. So this is about the whole system. It's not about the mental health provider. You've got them as well as you can do. It's the whole system, and that's why in here there's reference to MAID, so multi-agency discharge events. That's where you work with the whole system to say what are the reasons why these people can't get out and what are the potential options to prevent those delays in the future.
And this is something you deal with later in your report, where you set out something called the 10 high-impact changes.
Yes.
Those presumably being designed at improving mental health inpatient care and improving that process of making sure people can be discharged at the right time.
Yes.
You also say at 3.19 that those waiting in the community for beds were not visibly reported. Can I just ask for clarification? What do you mean by that, not visibly reported?
So they didn't appear in national reporting by and large. They didn't often appear in trust board papers. They didn't often appear in commissioner, regional or ICB. At different times things were called different things, but they didn't appear in those higher level commissioning reports. They tended to appear in what were called daily bed management meetings. So the local provider would know we've got 4 people waiting for a bed, we've got 3 people out of area, we've got 2 discharges coming up, how do we juggle that? But that was then not centrally collated in any way, so those people were invisible. And that backward pressure on community teams to try and keep muddling through with people who had been identified as needing inpatients, but it was very frustrating for those staff and very frightening for those staff sometimes because you're trying to manage someone you know you can't manage. But secondly, it also took a lot of time away from dealing with other people because you were having to put extra time into them to try and do the best you could. So and because they weren't being reported, they were like not considered. Whereas we've now moved to trying to move to more transparency, more trust boards, and we've pushed, in my GERF work, we were pushing ICBs as well, to include in your bed figures those waiting in the community, those waiting in UEC, as well as those occupying beds of different types on a given day.
And just going back to the question of delay, you deal with the impact of delays at 3.20, and you say there typically that subsequent admission would be longer. There's an increased risk of harm to the patient and others, presumably while they're waiting for admission. There would also be more pressure on community and inpatient staff. And you also say that people not deemed at risk of serious harm to themselves or others would often be deprioritised.
Particularly, they were using this very narrow framework of immediate crisis, immediate risk, rather than preventative.
I want to move on now within assessment to deal with assessment admission under the Mental Health Act. And again, we're only going to touch on this in outline and deal with the key principles. And you deal with this from 3.22 onwards. There are specific principles and guidance and indeed statutory provisions that apply to detention under the Mental Health Act. Is that right?
Yes.
And the Mental Health Act, in summary, provides that in some circumstances someone can be detained for assessment and indeed treatment without their consent.
Yes.
And at 3.23, you highlight the fact that Section 2 of the Mental Health Act provides for detention for assessment followed by treatment. And Section 3 provides for detention for treatment.
Yes.
And you set out there that a request for assessment under the Mental Health Act can come from a number of sources.
Yes.
And you describe there how assessments under Section 2 or 3 of the Mental Health Act require 2 doctors.
Yes.
One has to be approved in line with Section 12 of the Mental
Yes.
Health Act.
Yes.
And there also has to be an approved mental health professional. Is that right?
That's the bit that was corrected and is not in the report. So an approved mental health professional or the nearest relative. Nearest relative is extremely rare, but they legally, in some circumstances, can make the application.
And just pausing there, and just perhaps to illustrate the breadth of where requests for assessment under the Mental Health Act might come from, what's the sort of range of places you could receive that request from?
So it could come from the family. The family might phone the community mental health team. They might phone the social services department and say, can someone come and assess this? The police might do that. An A&E department might do that. A GP might do that. The courts may do that. The police, the criminal justice system may do that. There's a whole range of. There's no limit really on who can raise the issue about is a Mental Health Act assessment required.
So in effect, anyone, but might you expect to see it coming through, for example, A&E? Might that be one source?
A&E is one source, like I say. Technically, you can't just ask that an assessment's done on your neighbour, but there may be circumstances where that would be appropriate. So I'm not saying anyone could just ask for it and it will happen, but you can ask, is it appropriate for mental health assessment done? And then someone has got to decide whether or not an assessment of the Mental Health Act is warranted based upon the information they've received.
And generally speaking, the decision as to whether the assessment is warranted, where does that happen?
That will probably be most often with the community mental health team, the psychiatrist on that particularly, but it may be with the social service department, it may be with a social worker, it may be with an AMP, AMHB. So it depends where the request has gone to, and then who knows the person, and things like that. So it's very difficult to say this is what must be done. In general, it's a pragmatic decision based upon who is likely to be in the best position to decide whether or not this is the right thing to do.
And in your experience, is it common for approved mental health professionals and Section 12 approved doctors to be unavailable for those types of assessment? Is that a problem that was common during the relevant period?
Unavailable, no, but available quickly and in a timely manner, yes. So it isn't that they were never available, but there may be a long delay whilst waiting for them.
So would it be fair to say delays was perhaps one issue associated with those assessments.
Delays are one issue, particularly out of hours when there may be very few staff available to do it.
And again, it may be an obvious question given your previous answers, or probably obvious answer, but what impact do those types of delay then have on the person being assessed?
One, there is no legal framework under which people can manage the situation. So if that person says, right, I'm not going to wait, I'm going to go, there was no legal framework for addressing that. So if you were seeing someone at home and they said, right, I'm leaving, you couldn't actually prevent them leaving or whatever. So practically, it might make the assessment more difficult. So sometimes you would end up having to chase people to try and get an assessment done. They would become, generally speaking, the longer you wait for something, the more anxiety arises, the more frustrated you get. So by the time the assessment was done, they may be in a worse state, less cooperative, less willing to consider other options. So it's not a good thing. Sometimes they will abscond and harm would occur whilst waiting for that assessment to take place. Abscond is not the correct word there. Sometimes they would leave because they weren't detained at that point. They would sometimes leave where they were, and by the time they were found again, harm might have occurred.
Thank you. Moving on to the criteria, and again, just touching on this in overview, you deal with the criteria under the Mental Health Act at 3.24, and you make the point that criteria are broad, including detention being for the person's health and or safety and or for the protection of others.
Yes.
And you point out that's much broader than imminent likelihood that the person will seek to deliberately harm themselves or others.
Yes.
And you set out that balancing any risk and seeking to prevent misuse, a key guiding principle in the Code of Practice, the Code of Practice being what sits alongside the Mental Health Act, is that right?
That's correct.
Is least restrictive practice and maximising independence.
Yes.
And you say that important safeguard of least restrictive practice is a term often wrongly used in practice. You say the code makes the definition clear that where it's possible to treat a patient's safety and lawfully without detaining them under the Act, the patient should not be detained.
Yes. And what I mean by that is that sometimes people say least restrictive practices, we don't treat them at all, which is not what the Code of Practice says.
Can you just explain that?
People will say, because someone's not willing to cooperate with the plan, there's nothing we can do because that's their choice, least restrictive practice. Often you can negotiate with people about which aspects of the plan they'd be willing to go along with. It's not a binary thing. It's not, for admission, it's a binary thing. You either consent to the whole care and treatment plan or you don't. But for community, it's often not a binary thing. It's often a discussion, a haggle about which bits you're willing to accept, which bits you aren't. So saying least restrictive, they don't want to do this, so the person's got capacity, they say they're going to kill themselves, we don't think they're detainable under Mental Health Act, therefore under least restrictive there's nothing we can do, is a complaint which came up not infrequently during that time from families and indeed people who survived. And the answer is that was wrong. What you should still have been doing is trying to work out how you could safely and lawfully give them the best treatment you could in those circumstances. I know that's
yes.
It's difficult to do in general. It's more, it's about specific cases, but it's.
I'll come back to that if I can.
Okay.
It might make that point clearer. But in terms of the principles from the Code of Practice and the guidance relating to the Mental Health Act, is it right that they essentially remain the same throughout the relevant relevant period in terms of the core principles?
Yes, the 1983 Act, although it was amended and updated in 2007, the basic principles didn't alter.
And just asking about least restrictive practice, that's one principle from the Code of Practice, and that's a guiding principle amongst a number of other guiding principles, is that right?
The Code of Practice had a lot of different principles in it, absolutely.
The code of practice is, however, guidance only.
It's statutory guidance, but it still is only guidance. It can't cover every eventuality.
And in your view, is that guidance adequate, generally speaking?
There has been a recent revision of the Mental Health Act, as you will be aware, and I understand that part of that will now be looking again at the code of practice and whether or not, with further experience, it needs revising. I'm not party to how much revision will take place, but I understand that revision of the code of practice is planned. So it's fair to say that there's a view that it's not currently as fit for practice as it was when it was designed, but I don't know whether that's a minor alteration or will be major alterations.
Can I just deal now with the interaction between the Mental Health Act and also the Mental Capacity Act? Again, this is a complicated area, so perhaps I'm only going to deal with it in short form. Is it right that, in summary, a person who has full capacity can nevertheless be detained under the Mental Health Act if the criteria in Section 2 or 3 are met?
Yes.
So just to give an example, would it follow there may be circumstances where somebody has capacity and where detention under the Mental Health Act may still be required to stop them taking their own life?
Yes.
Just finishing this section of your report at 3.28, you say that in summary, increasingly as the century progressed, getting admission at the optimum time to a local bed became harder, but most admissions were and are to a local bed.
Yes.
And you also say that bed pressures were mainly due to the rising length of stay rather than rising admissions. And you make the point that more timely admissions would likely reduce the length of stay.
Which in turn would free up more beds to be available when needed.
Dr. Davison, that deals with your section of the report on assessments leading to admission. I want to now come on to what happens when a patient is admitted and arrives on an inpatient ward, and I'm going to turn my questions now to Ms. Nelligan. But Chair, I'm conscious of the time. I don't know whether that might be a convenient moment to break. Thank you.